Good morning and a warm welcome to our live Global Breast Cancer Tumor Board on this, the 11th day of September 2017, and a special thanks to our three doctors presenting cases today. From Tbilisi in Georgia, Dr. Nina Vardishvili and Dr. Natia Jokadza. From Buenos Aires in Argentina, Dr. Mayra Ferreira. From Fortaleza, Brazil, who haven't joined yet, is Dr. Conseco Campos. And a warm welcome to our breast cancer panelists. I just want to announce those that generally attend and that we're expecting. Myself, Dr. Paul Goss, Susan Sager, and Michelle Specht, and Alphonse Tagian. And Van is here in Boston with us. He's from Armenia. From Stanford University, Dr. Carol Marquez. These are all people that may join. From Tufts Medical Center, Jack Urban, Medical Oncology. From Johns Hopkins, Vered Stern and Jean Wright. From the University of Pennsylvania, Dr. Dela Cruz in surgery, and Dr. Ira, thank you, Ira, Dr. Ira Blauweiss in pathology. From Duke University Medical Center, Dr. Jennifer Plichter. From Rhode Island, Dr. Don Dizon. Thanks, Don. Nice to join you. And Dr. Mary Ann Fenton, all medical oncologists from Rhode Island Hospital. From Dana-Farber, Dr. Brittany Bashowski, and from Northwestern University, Dr. Swati Kulkarni. Some housekeeping rules, please. May I please remind everybody to keep your microphones on mute unless you are speaking. The PowerPoint cases and the YouTube recording of today's discussion are being archived online for viewing after today's tumor board. So there's no need to take notes at all. Whereas all key references and clinical trials cited in the tumor board, including a link to NCCN guidelines, will be sent to all attending the meeting today. And with that introduction, can we please get started? So I think we'll start with Tbilisi. So when you're ready, just 1 second, please. We're going to share the slide. We're going to start, Dr. Vardishvili. We'll start with you. Okay, there we are. Can you advance the slides?
Am I sharing?
Right, okay, that's fine.
1 second, let me make sure I'm sharing.
Can you see the slides?
No, I can't see slides.
Yes, 1 second. Actually, I did.
Can you see them now?
Yes.
Oh, awesome.
That's good. 1 second, Dr. Vardishvili. Okay, you can present when you're ready, please.
Okay. This case is about 30 years old female, premenopausal, who has 2 completed pregnancies, no family history of cancer, no comorbidities. In the 3rd quarter of 2016, she presented right breast lump with during breastfeeding. Next slide, please. She underwent diagnostic workup. Mammography reviewed 2 microcalcified shadows in upper quadrants of right breast. Breast ultrasound showed 3.0, 1.5, 2.5 centimeter axillary subclavicular lymphadenopathy. Biopsy showed invasive ductal carcinoma grade 2. Peer positive, HER2 CISH positive. Next slide, please. In the 4th quarter of 2016, she underwent surgery, radical mastectomy. Pathology reported was the same. So the patient has right breast cancer, PT2, M3, M0, 3C stage, ER positive, HER2 CISH positive. Genetic test BRCA1 and BRCA2 was negative. Next slide. Then she underwent adjuvant treatment. We started with chemo, AEC, followed by taxane. Then she received radiation therapy, 50 days, and endocrine and target therapy with goserelin plus exemestane and trastuzumab till 1 year. Then she received biphosphonate rescue with zoledronic acid every 6 months. And this is my questions. Which endocrine combination is better to use in young women? Goserelin plus exemestane or goserelin plus tamoxifen? Rationality of biphosphonate therapy in N3 disease. Other option for prolongation DFS.
Okay, so we'll have a conversation. Susan, I see you there. Can you hear me? Susan, so the question is, thank you for joining. The question is, which combination is better to use in young women? Goserelin plus exemestane or goserelin plus tamoxifen?
Yeah, so I think the management of this case has been superb. So I think the ideal choice for endocrine therapy is what was chosen, particularly in the age group under 35. So we know from the combined analysis of the SOFT and TEXT studies that patients who received ovarian suppression plus an aromatase inhibitor did much, much better compared to tamoxifen alone or ovarian suppression plus tamoxifen. So in that combined analysis, although it was a subgroup, there was about a 15% difference in benefit. So I think what was used here was perfect.
And may I just say about the bisphosphonate, whether you believe that bisphosphonate independently shows benefit in breast cancer, we use it here because the patient's undergoing ovarian suppression and there's tremendous bone loss. In a premenopausal patient who has oophorectomy or goserelin, there's about a 15% loss of skeletal mass in the first year. So it's very important to use bisphosphonate in these patients particularly. There's almost a double reason. So even if you're a believer in the role of bisphosphonate, for bone sparing effect, it's useful to use it here. Susan, there's a question about other options for disease-free survival, perhaps chemotherapy or other therapies?
Yeah, so I think, you know, in someone with, she had N2 or N3 disease in this country, we would have normally considered adding pertuzumab to the Herceptin. I don't know whether that was available to the team that's caring for that patient. And then I guess the other thing you could consider, and again, I don't know what's available worldwide, is the use of neratinib, which is another HER2-targeted agent. I think, you know, at this point, the neratinib in the United States is approved for patients who are within 2 years of completing a 1-year course of Herceptin or trastuzumab, and the absolute benefit was only about 2%. So, you know, that was in all comers. So you would guess, although I can't point to data showing it, that patients with more advanced disease, particularly this type of patient, may have a larger benefit from the use of that drug.
What about chemo, Susan?
I would not. I think this patient has had a lot of chemotherapy. There's no data to guide that.
Right.
I don't know. There's other panelists on the call that have an opinion. Jack, I see your.
Yeah, sorry, I had a technical problem, but thank you. I think it's an open question, and you know, based on the CREATE-X trial, one might argue that there may eventually be a role for chemotherapy such as capecitabine after surgery like this, but in that trial it was clear that even in the population tested, that ER-positive patients did not really benefit. The benefit seemed to really mainly accrue to the PR negative patients. So I agree. I think that the role of additional chemotherapy is unproven in this population.
So I had a question for the group, if I can, Paul.
Sure, Don.
So Susan, nice to see you. In terms of the affinity data that looked at adjuvant pertuzumab, it was striking that the DFS advantage was so incredibly small. So what are your thoughts about adding adjuvant pertuzumab to this kind of therapy? I'm actually fine with her not getting it.
You know, I think everything we do in medicine is based on proportional benefit. And so this patient has such enormous risk statistically with that N3 disease. So if anyone's going to benefit, she would be the person that I would think would have the greatest benefit. So I personally would use it, or would have used it. It's an expensive drug, but she's got a lot of risk here. I mean, we know patients who are have pregnancy-associated breast cancers do significantly worse. So we've got multiple negative prognostic factors in terms of age, pregnancy-associated, plus high-risk nodal disease.
We published a paper on this very recently, Susan. The majority of pregnancy-associated breast cancers are triple negative, and they have a very poor prognosis. But so do the HER2 positive or whatever, the comparable non-triple negative. Let me put it that way. The non-triple negative pregnancy-associated breast cancer have the worst prognosis than their normal counterparts. So I think Susan is correct in saying that pregnancy-associated breast cancer, believe it or not, is defined in the literature as within 10 years of a recent pregnancy. So it's not just breast cancer in pregnancy, it's breast cancer up until 10 years after a pregnancy.
Well, I think, Paul, I actually will challenge that only insofar as it may not be that the pregnancy is influencing the prognosis. I've actually always been impressed, and granted, I've been away from breast oncology for 5 years or so, but I have always been impressed that women under the age of 40 do particularly poorly with invasive breast cancer. And
it's true what you're saying, Don, but even so, taking that into account, compared to this definition, if strictly defined as pregnancy-associated breast cancer, has a worse prognosis. There's something about, I don't know if it's a genetic or predisposition. In fact, we've written a research study, which we have not yet done, with Dr. Winchellbaum at Mayo Clinic, suggesting that we test the general population of women for a abnormal genetic profile or polymorphism that predisposes to post-pregnancy breast cancer. But I think they do worse, even what you're saying, Don. It's true what you're saying, but I still think they do worse. I think matched against sporadic breast cancer in age match, they still do worse.
I think regarding the question of pertuzumab, as Susan mentioned, I think proportionality is important here. On the one hand, the group that benefited in the Affinity trial clearly was the high node burden patients, but on the other side, the patients who were ER/PR positive did not really benefit significantly. And again, it's always the question of, at least in that trial, is it given, whether it's given with Herceptin or with chemotherapy, does seem to affect the efficacy of the anti-HER2 drugs. I would say if it were available and the patient has this burden of disease and risk, it'd be reasonable based on her node count to consider it as adjuvant treatment.
Right. I think there's consensus on that, Jack. Thank you. Is there any other points that the panel would like to make about this case before we move on? Thank you very much. That was a very interesting case. Myra will go next.
Paul, could I make one other point about this case? Because it really was fascinating, and it didn't get brought out, I think, because one of the questions I think that was being asked was, is the choice of endocrine therapy so clearly an aromatase inhibitor? Am I correct in that? Was that one of the questions?
Yes.
Yes.
So it'd be very interesting to know that an after analysis of the soft and text trials, as I understand it, that about 10 to 15% of the patients only had HER2 positive disease, and the majority got chemotherapy, but only about half ended up getting anti-HER2 therapy. So that was about 560 some odd total women that got treatment. And based on some of the science between anti-HER2 therapy and tamoxifen, it's not exactly clear that the benefits of the aromatase inhibitor are going to conferred to the HER2 population. I would use the aromatase inhibitor myself, but it's not so clear that tamoxifen in this population wouldn't have equivalent benefits. At least in preliminary analysis, it suggested that the two hormonal therapies were equivalent.
How would you ever find that out apart from conducting another trial?
I'm sorry, could you repeat, Paul?
How would one ever find that out and confirm what you're suggesting other than through another clinical trial?
Right. I mean, I think they're waiting for some central analysis. This was all based on site analysis, but you're right. I think it would require a whole nother trial.
Thank you, Jack. That's really interesting. Susan?
Yes, so my question is long-term to you, Dr. Goss. How many years of ovarian suppression would you recommend? Would you stop at 5 years in this patient, given her risk? So I think I'm more struggling with what to do long-term in these young, healthy people. Do you put her on tamoxifen alone in 5 years? I don't know if there's any data to guide us, so I'd be interested in opinions.
That's a really interesting question. I don't know of any data that asks that exact question, so I think we are data-free on that point, but it's a very interesting point. I suppose it would be reasonable to put on tamoxifen 5 years. Seeing as there's such a small difference, if any, as Jack said, it may be advantage to tamoxifen over exemestane, perhaps after 5 years she should be switched to tamoxifen.
One other point, if I could, Paul, because I know the question of bisphosphonates was raised in the discussion, and the only point I would make there, and I'd love to hear the panel's opinion on this, is that I've frequently had the situation of young women in their 30s who have told me they will consider having another child. And it will be, and in this case, of course, there's extreme risk, but in other cases, the risk isn't quite as high. And I've always been reluctant in those cases to use bisphosphonate because the terminal half-life of that drug is enormously long, and it's not clear at all that there's a safety record in patients who might become pregnant. Does anybody have an opinion on that? I personally would not use it if the patient ever expressed a desire that they might want to become pregnant again.
I don't know what other people's opinion is, but I concur with you, Jack. And it also raises the question of fertility, raises the question of whether exemestane or tamoxifen are used up front. I think it's easier to become pregnant and to switch off exemestane than tamoxifen. Tamoxifen has a very long tissue half-life and may be teratogenic to the fetus. So tamoxifen, the woman is often subfertile after tamoxifen, and there's a potential hazard to the fetus. So if there was a desire for pregnancy, I would favor exemestane for that reason, because it can be quickly reversed in favor of becoming pregnant. So I think go ahead.
Well, I mean, well, I think in a case like this where you're going to be suppressing the ovaries, Jack, I probably would have no problems giving her a bisphosphonate as long as she was on the suppression. Given the terminal half-life, I think she is not going to get pregnant as long as you suppress her. But Paul, in terms of the tamoxifen versus exemestane question, I mean, we used to use tamoxifen to stimulate the ovaries, and I know you have as well. I've had plenty of patients become pregnant on tamoxifen, and they have to stop it if they do get pregnant. So I'm not sure that's
but there's also equivalent and better literature showing a post-tamoxifen variability in fertility. And there's definitely more information on the teratogenicity of tamoxifen than the aromatase inhibitors.
Well, but if you looked at the data from Kutluk Akte from Cornell, when he tried to do some ovarian stim, again, and for breast cancer using an AI, there was a higher, if I remember the data correctly, there was a higher teratogenicity rate with an AI rather than with TAM. Again, totally separate apples. We're talking apples and oranges, but in terms of the desire for pregnancy, I actually would favor the use of TAM.
Okay.
Don, just a fine point on what you were saying. I agree with you about during, but there have been studies that have shown that even a year or more after stopping bisphosphonate, you can measure excretion of it in the urine. And so my concern was really what happens a year or two after the patient has actually stopped her drugs. There's still evidence that the drug is in the system, and for that reason, I think I would be cautious.
But that creates a conundrum, Jack, because bisphosphonate is the commonly used indication for bisphosphonate is in the premenopausal, being rendered postmenopausal. So,
oh, yes. Yes, she has absolute, from her cancer perspective, I agree with you, Paul. She has an absolute reason to include it at this time from the prevention of cancer. But as we both know, there are patients who have chosen to, let's say, compromise their hormonal therapy in the search of a pregnancy. And I guess I would have to have that discussion up front before the patient even started her treatment.
I think you're right. Susan, what's your practice with bisphosphonates in young women?
Yeah, so for patients who upfront are saying, I want to get pregnant within 2 years, I've been withholding, based on the lack of clear safety data. In this patient, I would encourage her not to become pregnant, and I would strongly recommend use of the bisphosphonate.
I mean, to apply that rule in all premenopausal women, when there's a convincing 10% loss of skeletal mass in the first year after an abrupt ovarian suppression in a young woman, it's hard to resist using the bisphosphonate for that reason. I've always viewed it like that. I would generally discourage pregnancy, obviously, and I wouldn't. I think I concur with your pregnancy concern. But I lean in favor of using bisphosphonate in young patients than not, because of the skeletal risk and the skeletal damage long term. I don't think we even know the real long-term risk of osteoporotic fractures in young women who are rendered prematurely menopausal.
Right. I think, Paul, the only thing that I would add to this case, given the concern for bone health, and I think it's totally legitimate. I favor Susan's approach to patients like this, but it's also as important, maintaining healthy lifestyles, maintaining activity levels. All of this is also very important. It's the subject of an alliance trial, I believe, just healthy lifestyles. That much in terms of her survivorship goes hand in hand with everything we can do with her medically. And I should also point out that if she hasn't had a discussion about sexual health concerns, that also needs to happen, because if anything kills sexual dysfunction or causes sexual dysfunction in this population, it's goserelin.
Right. Those are all very good points. Thank you, panel. Myra, would you like to present the second case?
Yes.
Just 1 second, please.
Okay.
This is the case being presented from Buenos Aires by Myra. Next slide. Next. We're ready now, Myra. Thank you.
Okay. 45 years old female. She has in 2006 diagnosed with cancer, ductal carcinoma, ER/PR positive, HER2 negative, and she started neoadjuvant chemotherapy with cyclophosphamide and doxorubicin for 6 cycles. 1 year later, she went to surgery now, 1.5 centimeters in the mastectomy, and she had positive axillary nodes, 7 from 13, and she went to radiotherapy and tamoxifen for 3 years. After that, in 2010, she switched to anastrozole and continued under control until 2011, when she had a positive bone scan in lumbar 4. Chemotherapy endovenous, because she went to capecitabine and pamidronate. She went to surgery in the spinal cord and continued treatment with capecitabine and pamidronate from 2011 until 2015. She continued with performance status 0, had a normal life, and she continued working, and no pain. Until 2015, when she presented neurologic symptoms, and the MRI was positive for brain lesions. The treatment plan was neurosurgery, partial metastasectomy, and radiotherapy, and the metastasis was disease ductal carcinoma. At that moment, she started paclitaxel and bevacizumab every 15 days, and continued since 2016 until now, when she presented pleural effusion.
So perhaps we can have a discussion before addressing your questions, Myra. We'll come back to the questions at the end. Let's just have a discussion first with the panel.
Excuse me, Myra, can you tell us, was the ER, PR, and HER2 status repeated on the tumor that was resected from the brain or in the pleural fluid?
No, unfortunately, we don't have immunohistochemistry.
You know, I think it's interesting. Your choice of AC for 6 cycles, is that the standard in Buenos Aires?
Yes.
It is. Oh, so here we would have given her AC for 4 cycles followed by Taxol for 4. You know, I haven't seen, you know, we used to give a lot of CMF for 6. I haven't seen 6 cycles of AC in quite a while. But, you know, I think your first question, though, is very provocative.
I know, that's the reason that I chose this case.
Sorry, let's have a discussion around the use of Avastin. Susan, would you and then Jack like to chime in about Avastin, and Don?
You know, it's not a drug that we typically use for breast cancer. I mean, there have been some positive studies, but many more negative studies. It's a very expensive agent, has side effects. You know, if I look at the use of bevacizumab, Avastin throughout all disease sites, it tends to be most helpful for patients with ascites, or I would put pleural effusions, and it tends to decrease the amount of vascular leak or fluid accumulation. So it's not a drug I've used for breast cancer, except as part of a study, I would say, in recent years.
Jack, I guess we're old enough that we can use it.
What's that, Don? Just say it again, Don.
We're probably old enough, Jack, that we used to use this drug all the time in breast.
So yeah, so I was part of the Eastern Cooperative Oncology Group, and continue to be, where we were participating in the randomized trial of paclitaxel Avastin versus paclitaxel alone in first-line metastatic disease. And as everyone knows, that study led to an approval by the FDA for use. And there was a sense that in patients who were in visceral crisis or who had a substantial disease burden, that there might be, quote unquote, some activity. Ultimately, numerous other studies suggested that the relative benefit toxicity could not continue to recommend it as approval by the FDA, and so it was withdrawn in 2011. And subsequently, ECOG adjuvant trials have shown absolutely no signal in the adjuvant setting for Avastin. So as an anti-cancer therapy, I guess in the adjuvant model, there was absolutely no benefit that the drug reduced recurrences. That said, I think that there are several suggestions in certain metastatic disease settings, namely effusive diseases or visceral crisis in the liver, where a high amount of where early activity may be enhanced by combining it with the drug. I have not used it probably in 3 years or 4 years in metastatic disease, preferring to rely on single agents or other combinations of therapy that have been effective.
Excuse me, Dr. Conseco, we can see you now. Fortaleza, Brazil, we can see you.
Hi.
Thank you. Jack, so in conclusion, I know we've got some dubious role of Avastin in cervix cancer. Is this a drug looking for a home?
Well, I think it's looking for perhaps a better designed trials and perhaps a biomarker to understand exactly for whom it may be beneficial. And I think that's the message. As everybody knows, the target for Avastin is a compound or a chemical known as VEGF, but the other name for VEGF is vascular permeability factor, and vascular permeability factor is responsible for effusions and for the capillary leak that is occurring in pleural and peritoneal effusions. So I think it's really more an issue of whether we have a proper biomarker, and it suffered because we really never had a proper marker to determine who should get the drug. HER2 had a much better time of it.
Jack, we're speaking to South Americans with limited financial constraints on their medical budgets. I don't think, as we've concluded in gynae cancer, that Avastin at $100,000 for a 6-month course plays a substantial role in the treatment of this or any other disease.
Well, Paul, I have to correct you there. Remember that Avastin is a drug that Susan and I use exceptionally commonly in gynecologic malignancy. It is approved in cervix and first line. It is approved for recurrent ovarian cancer, and it is frequently used with weekly paclitaxel in endometrial cancer. And the basis for my use of that is the old ECOG study, not because of the activity signal, but because of the tolerability signal. So, you know, when ECOG's data was coming out, Genentech launched 2 trials as well. Jack, you might remember this, the Ribbon trials, Ribbon 1 and Ribbon 2 in metastatic breast cancer with Avastin. And, you know, I was impressed, and unfortunately there was no signal, but I can tell you that the patients I placed on that trial on Ribbon, some of them had the most phenomenal responses that I ever would have predicted. So I was actually very disheartened when the FDA withdrew the label for metastatic breast cancer using bevacizumab. But the reason we don't use it and Susan doesn't use it is it is not available by compendium or by insurance label for the use in metastatic breast cancer in the United States.
But Donnie, isn't it true that it doesn't, this is beyond this tumor board, but it doesn't, it adds something like 2.2 months to survival in cervix cancer. So in that case, we indicate.
Yeah, so, well, I mean, it is beyond, but the bottom line for metastatic cervix cancer, none of our trials ever extended survival beyond a year except chemotherapy plus Bev.
I see. All right. So do you use it frequently in that circumstance?
We do. It's our first line, I think, for metastatic cervix cancer. Our go-to in the U.S. is carboplatin with our cisplatin paclitaxel plus bevacizumab.
So would you advocate it for financially constrained countries in South America?
For cervix or for cervix, you know, I think it's something that we need to advocate for. But I know for a fact that, like you just stated, resource-poor countries are probably better off investing in prevention programs like vaccination and screening rather than bevacizumab for metastatic cervical cancer.
Right. Well, thank you very much, Don, for enlightening me. That's interesting. Thanks, Jack. Thank you, Susan. Now, can we have, I think Fortaleza is on the line. Susan, thank you very much. Just to share, your case is the third case. So thank you for joining us. I know you had trouble, but that's great. Can you share the slides? Is there another question?
Okay, I just thought there was another question.
There wasn't a question from the previous case, so we'll go on to the third case, if it's all right. 1 second, Susan. Okay. We just about ready. Thank you very much, Susan. Present your case, please.
Thank you. Sorry for the delay. Good morning, everybody. It's a case about a young lady, 29 years old, and she had no family history, and she noticed a breast mass when she was breastfeeding, and her exam at the first consultation was abnormal. There was next please, I couldn't. Okay, and there was a breast mass. I have no images of her because as I am a radiation oncologist, she was referred to me after that, but she has a left breast mass, and an enlarged axillary left node. And she did some diagnostic exams, and she was sent to the medical oncologist to do new adjuvant chemo. So the exams are here, and you see the CT scan, and it shows her her breast with the disease, and the nodule in the axilla. And at that time, she had some abnormal images in the liver, and she had a magnetic resonance that showed only one solitary lesion in the liver, and the biopsy was positive for invasive ductal carcinoma, ER 10%, PR negative, HER2 negative, and Ki67 40%. So as she was diagnosed with this liver metastasis, as she was in 4 stage, and she changed the initial concept of neoadjuvant to palliative, but she had some problems, and that's why I brought this case. Although she was a private insured patient, she got a lot of problems of getting her medicine and cycling accordingly. So the lesion became to grow, especially after the adramycin chemo, when she was in Taxol, and she did 9 Taxol, and she was referred to her surgeon to have surgery because it was developing in the breast, although in the liver the mat was not seen anymore. So, oops, another one. So she was, sorry, she was the procedure, the surgical procedure, due to this breast progression, was not realized, and she had neoadjuvant radiation because the lesion was going to bleed, and that's why she was referred to me. And she got this scheme. She had 60 gray to the breast and 50 gray to the vaginal lymph node irradiation, and she was finally operated after that, and she got only lesion in the breast. And after that, when she was referred back to the medical oncologist, she had the disease progressing all over in a PET-CT scan, and she now is in the palliative chemo with this scheme that's shown. Well, my questions are just because although it's not a public insured patient, and she had all these problems. She didn't get capecitabine with radiation, and didn't cycle accordingly. And I would like to ask you the chemo options for her in the very first beginning, and if you see this situation of neoadjuvant radiation for these metastatic patients very common. Thank you.
So with the panel, okay, great. So I'm just getting some feedback from Mike. Okay.
Is it all right? Can you hear me all right, Paul?
Thank you, Jack. Please comment on the case.
Yeah, very difficult and problematic, obviously, because of the refractoriness of the disease. In the beginning, it's always a question with 10% ER. Are we dealing with a ER positive tumor, a potentially false positive signal, or a biologically really an ER negative cancer? And I guess at the start, one could have asked the question of the role of platinum in a situation like this, where for neoadjuvant data purposes, I think it's reasonably clear from phase 2 data that the response rate in neoadjuvant to triple negative behaving breast cancers might be higher with the addition of platinum, even in BRCA unselected patients. Whether it translates into disease-free and overall survival advantage is completely unknown, and I do not recommend using it for all patients with triple negative breast cancer. But for those who need a greater response for surgical reasons, it's reasonable to add a platinum to the taxane. At this point, she has several options for drugs. I think one would be eribulin. A second, based on a study that we participated in years ago comparing Taxol to Taxotere, would be that if Taxol was used as the initial treatment, docetaxel or Taxotere could be considered even in paclitaxel-resistant patients. There was about a 19 or 20% response rate in those who were truly refractory to Taxol. So I would say either eribulin or paclitaxel. And the BRCA Taxotere, and the BRCA analysis was completed. Is that correct?
Dr. Campos?
She had no BRCA analysis.
She didn't have that done.
She didn't.
Okay, fine.
So I think a platinum is a reasonable consideration in a case like this.
Jack, do you take exception to the use, technical exception to the use of neoadjuvant for a patient who had a solitary liver metastasis from the beginning?
Well, it's a great question. And I would say that if I was convinced that the patient had an isolated metastasis and was trying to control their local disease, I would agree with the approach that was taken, only because I think there's a consideration for ablative therapy in very selective cases. I have not an ER negative patient, and I know it's a different situation, but I have a patient who presented similarly with 10 positive nodes and an isolated metastasis to the liver that was ablated 21 years ago, and the patient has never experienced a recurrence. So on a case-by-case basis, I suppose that the approach was reasonable, with the options open to consider multimodal therapy depending on the response.
But Dr. Bleiweiss, was this biopsy proven liver metastasis, please, Susan?
It was not made. The biopsy was not made. It was just
understand. So she had no. Is it easy to make a solitary diagnosis of solitary liver metastasis, Dr. Bleiweiss?
I'm not sure what you mean by easy. I mean, if the tissue is adequate, sure.
On a core biopsy of the liver rather than excision?
All the time.
No, I'm saying, would you advocate for a core biopsy of the liver or an excision?
I mean, a core biopsy, if it's targeted correctly and gets enough tissue, is fine. I don't know how big the lesion is.
I think. Are you talking about for therapeutic reasons or diagnostic reasons?
Diagnostic reasons.
Yeah, diagnostic biopsy.
Yeah. I mean,
I'm sorry, was she pregnant when she first presented, or am I reading that completely wrong?
She was breastfeeding, so she also was she had delivered at that time of the diagnosis.
So what you've done, you've called you want to radiate her breast for local control, but that's after she has a known liver metastasis, so that wouldn't be considered neoadjuvant radiation, technically. Am I correct, or am I got it wrong?
Well, you know, I have a tough time calling anything in this case neoadjuvant in the context of probably a liver met. I think she was probably correct in the beginning when you called it all palliative. I mean, I think the discussion points you raise here are things we still struggle about. I believe it's like, what's the role of surgery with stage 4 Mets? Is there a role for total mastectomy? Is there a role for radiation if there's a chemotherapy non-response? You know, all of these questions are incredibly valid. They're very tough, like Jack was saying.
What is the clinical trial that will answer this question definitively? Because we've argued about this for as long as I can remember, 20 years or more.
Jack, Susan, you might want to correct me. I thought there was a surgical trial.
Yeah, there is the trial that's being run that's been ongoing for quite a long time, randomizing patients with metastatic stage 4 disease to completion therapy, which means treating the local regional disease as you would if it were an adjuvant situation, either complete surgery and radiation if indicated, or a partial mastectomy radiation, or if surgery alone is appropriate surgery. But it has to be effectively the complete therapy and not a partial lumpectomy or suboptimal treatment. And that trial is going on through ECOG and the cooperative groups, but it's been accruing relatively slowly.
I would imagine. I think we have this discussion so frequently about stage 4 patients having isolated oligometastasis resected, or even 2 metastases, or 3 or 5 or whatever. And it's a question that I thought we had answered many years ago, because the surgeons used to aggressively resect metastatic disease and it was incurable in the long term. And the answer to these anecdotal cases that are alive with the resection of their tumor is that those patients had indolent disease and would be stable or alive anyway. So it's been an ongoing debate in the literature, and I think that we argue about isolated pulmonary mets and liver mets frequently in the case of metastatic disease. I don't know what you think. Susan, what do you think about this topic?
Yeah, so kind of the approach I usually use is kind of what was done in this case, that I would start out with seeing if I can get a response to treatment. So what if this patient had a clinical complete response to your neoadjuvant chemotherapy? Then the decisions get harder. You have no disease anywhere. You know you started out with a tiny liver lesion. Or maybe there's a tiny bit left on a PET scan in the liver and the breast is negative. Those are the ones that are harder, because you have to ask the question at that point, would surgery, improve this patient's overall survival? And I think that's really the question being asked in the national study. But this run-in with chemotherapy, I kind of view it as a proving ground. How well is your therapy going to work in someone with rapidly progressive disease? In this case, I think you didn't have a choice but to radiate the breast. It was growing, it was bleeding. I don't think a surgeon would have gotten clear surgical margins and good local control up front, from what I'm hearing.
I want to add to Jack's comments about available chemotherapy options now.
So I think, outside of a clinical trial, eribulin would be my next line if the gemcitabine cisplatin doublet didn't work for this patient. And in this country, this type of patient who's young, who has a young family, we would recommend early palliative care, additional supports for this very difficult situation. There are issues of motherhood, of who's going to care for the child, and just the dynamics there must be very difficult. So I don't know the availability of palliative care teams in your country, but that would be the other thing that I would want early on for my patient here.
Would anyone be tempted to treat the disease as hormone positive, given the ER 10% stain? Jack, you had mentioned that before. I'm almost inclined to try to see if I could get her some mileage with an anti-endocrine.
Well, it's a good question, and this is such an interesting case for so many reasons. But that question also, in patients, as you know, NCCN guidelines or guidelines panels have included a trial of hormonal therapy in ER-negative patients with visceral or lung disease if there is several factors that indicate it's reasonable. For example, relatively indolent or changing slowly or minimal disease burden. And the whole premise is based on the fact that there may be errors in testing, and a hormonal therapy, even in truly ER-negative disease, is not out of the question. This patient bothers me somewhat in that regard because her disease is quite aggressively behaving, both in terms of her local regional disease and her visceral presentation. So I probably wouldn't be so inclined. But if she had had several lung nodules and a relatively indolent chest disease, I would certainly consider it as an option. As far as ablative therapy, just to go back to that and whether or not to treat stage 4 disease and as an ablative, I can only say I think we all have, and I have, as I mentioned, that liver patient who's 20 years out with never having a recurrence. I have a brain metastasis, multiple brain metastasis patient out over 10 years with HER2-positive disease, so much so that we at 10 years had to decide whether to continue Herceptin because she's been NED below the neck and above the neck since her initial treatment. I think we're going to be seeing with better drugs more and more patients where the metastatic disease is a oligo presentation and may not continue with time.
But whether we agree with each other about calling this neoadjuvant treatment or not, would the approach to the treatment have been different depending on what we call it, or would we all treat this patient similarly? It doesn't matter, it's just terminology whether we call it neoadjuvant or not.
Yeah, I think one question might be, would you have used single agent versus multi-agent therapy as we often do in the adjuvant setting? That I think is a debatable point, but I think we would all have taken, or I would have taken a similar approach.
But I sort of concur with you in one sort of funny way. I remember a patient of mine who was on an analog of tamoxifen as a clinical trial. And she had a pulmonary resection of the only oligometastasis in her lung. And after about 20 years, I couldn't get the drug anymore. I couldn't get it from the drug company. They refused to make it anymore, or they went out of business. So the drug was stopped after 20 years. This is an analog of tamoxifen. And immediately it was stopped. At the very next visit, she had pulmonary metastasis again, which she hadn't had for 20 years and for which she'd been under continuous observation. So it was highly suggestive of what you say. And that's why I think trying an endocrine therapy with ER positive 10% might be worth doing. If you're going to throw every other therapy at her, you may as well give her that.
I would actually go so far as saying that if you look at the historical data that we use in the US of not combining endocrine therapy plus any kind of chemo, there is very weak data from that to say that they counteract each other. There have been some trials in Europe that have combined hormone therapy with chemotherapy, which showed some sort of benefit. So if I was going to do an endocrine treatment, I would probably try to do it with some sort of chemotherapy. And
what would you do next, Don?
To tamper down on toxicities.
Is that what chemo would you give next?
What chemo would I give next? You know what? I think her prognosis is poor. I think we all kind of are sensing that. Susan kind of alluded to it. Depending on what's available locally, I'm kind of inclined towards Cytoxan, and I would use Cytoxan with an aromatase inhibitor.
So like low-dose oral cyclophosphamide.
Yeah, and I'd probably do that with letrozole or an AI or something. I think she's been beaten up with medical therapy at this point. So give her something, try to reconstitute her bone marrow, give her back some sort of quality of life, and see how far you get from that. I think her prognosis is poor regardless. She probably is looking at 12 months or less.
Susan, do you have any comments about this interesting case?
Yeah, so Normally what I try to do with endocrine therapy is get your initial response with chemotherapy, and then in someone who's 29, ovarian suppression, and add another agent, whether it's tamoxifen or an aromatase inhibitor. If I was going to add endocrine therapy now, if she's still menstruating, I would add ovarian suppression with any of the chemotherapy agents we've talked about. I think based on probably the biggest study I'm aware of combining chemo plus endocrine therapy up front was the TEX study. All of the women who received chemotherapy in the TEX study had ovarian suppression day one of their chemotherapy, and their results of that study were great. So I would feel comfortable with adding in ovarian suppression for this patient.
And not an endocrine agent per se.
I think she's got such rapidly progressive disease. If our goal is to try and get additional time for her with reasonable quality of life, you need her tumor to respond. I don't think single agent Cytoxan has the same success rate as eribulin would.
Okay, I'm sorry, I got my Susan's mixed up. Thank you for your comments, Susan. But Susan Campos, have you got any comments about your case? What were you thinking of doing next?
Yes, I will consider all this information and talk to the medical oncologist. And I thank you. I would like only to comment that we don't have enough palliative support, even for the private insurance patients here in my city.
Okay, thank you very much, Susan. So we're just about on time, and thank you very much to the panel for attending and for the presenters for presenting very challenging, interesting cases. Thank you, Myra. Thank you, Susan, and thank you, Sibilisi. And thank you very much, Dr. Blyweiss and Susan and Jack and Don and everybody else for attending. It was a very successful tumor report. Thank you very much. We're going to close up now unless anyone's got any more comments. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, 0. Thank you.